Joyfrida Chepchumba. I'm from the National Cancer Control Program, and in collaboration with the Kenya Network of Cancer Organizations and Janssen as our sponsor, we are having this webinar around prostate cancer treatment and survivorship. This webinar was aimed at the health workers, just to remind them about the prostate cancer treatment and to also hear the experiences of a survivor around the same area. And especially given that we are gearing towards Father's Day, we are hoping this will just raise awareness for all the men out there to get screened often for this type of cancer. So welcome everyone. In case of any questions, just drop them in the Q&A below and our panelists will address them. Okay, thank you.
All right, thank you very much, Dr. Joyfrida Chepchumba. At this point, I want to introduce Dr. Eric Mushangi, who sponsors for today, who made this meeting possible. Dr. Eric Mushangi is a medical manager, Sub-Saharan Africa from Johnson Pharmaceutical. Karibu, Dr. Eric will give me 5 minutes to introduce Johnson and to give a few remarks.
Thank you so much for the opportunity. It's such a chilly evening where I am, and I'm really looking forward to warming discussions on one of my pet subjects, prostate cancer. Like you've heard, my name is Dr. Mushangi. I'm the medical manager for Sub-Saharan Africa, working at Janssen. For many people that sometimes I speak to, they ask who Janssen is. And Janssen is one of the companies within Johnson & Johnson. I think Johnson & Johnson is sometimes more known. It's really the commoner term that is used to describe us. So Janssen is just one of the many companies that are within the Johnson & Johnson group of families. And here in Kenya, we have a presence in 3 main domains or disease areas. And one of them is the one that we're discussing today, prostate cancer. And so it is with a lot of pride and pleasure that we sponsor initiatives such as this that are geared towards driving education to the doctors, to the healthcare practitioners with whom these patients will be having an interaction with. It also gives us pleasure to know that we have like-minded partners in the name of KNH-UoN, in the name of the National Cancer Control Programs, and all the other programs that work in a very concerted fashion to deal with and provide solutions to the cancer situations that we have in our country. Allow me to just talk about 3 things briefly that Janssen is particularly keen about in the space of prostate cancer, and one of them is exactly initiatives such as this. The second thing I also want to speak about, and this is an important remark because I sort of reiterate this message. I've been reiterating this message in all the webinar series that we've had, such as this, is to say that Janssen also works very closely with partners such as NHIF to ensure that access is made to some of the innovative therapies for prostate cancer. Janssen in this country, Johnson & Johnson or Janssen manufactures and commercializes one of the hormonal treatments that is used in prostate cancer in this particular country. It's a molecule called abiraterone. I'm fully aware that this is not a promotional meeting and that's not the intention, but it's just to mention that together with NHIF, we have partnered to come together with a patient access program for cancer patients, so that cancer patients don't have to go into their pocket, looking for 500,000 shillings to be able to procure some of these medicines that actually have been shown to have, immense overall survival. This is improvement of quality of life that eventually, these patients can be able to enjoy with their families due to some of these novel therapies. So these therapies are available. Allow me to also recognize the Janssen team, whom I wish have logged in now. I think we have our country manager logged in, Madam Quinta Owoda. And I also want to recognize the team that works specifically in prostate cancer, that is Grace Humwa and Eric Ojuki. I'm sure some of you may know these individuals. In closing, I'm proud to see that the agenda is actually quite robust, 360. We are beginning by getting a perspective from the patient, but also we'll be getting some scientific insights from Dr. Misango, who is a friend and a colleague, but also Dr. Asaf, who actually is also a dear friend and a colleague. So this is really a star-studded panel, and I also look forward to the discussions that will be coming out of this. I'm proud to see that we are at 630 participants, and let me close it there and give it back to the moderator for the session. Thank you so much for the opportunity, and we ask you to really have a nice time. Thank you.
Thank you very much, Dr. Eric Mushangi from Johnson, and we do appreciate your continued support towards oncology. I will be inviting Dr. Asaf from the KEPCA. So I will be loading, let me try and load your presentation. Daktari, are you around? Maybe you can say hi to the people who've joined in before I load on your presentation.
Sorry, Elizabeth, this is Christine. Kindly, I think we can start with Dr. Samson as we are trying to ensure that Dr. Asaf gets in.
Okay, thank you, Christine. So maybe let me just stop the share, the KNH. Okay. So I will be introducing Dr. Samson Misango, who is our speaker for today. Dr. Samson Misango is a consultant general surgeon and urologist who is the head of the Department of Surgery at the Kiambu Level 5 Hospital. He's also the program director for SEXA at Kiambu Level 5 Hospital and the founder of Medical Surgical and Urology Meso Center in Parklands, Nairobi. He's also a private practitioner in Nairobi, Kenya and abroad. He's a member of various professional and social organizations in Kenya and abroad, and an active contributor on various topical issues of medical, social, and political significance, both locally and internationally. Dr. Samson Misango, karibu sana.
Thank you very much, moderator, for your kind introductions, and good evening to all the participants who are joining us today. I will have to apologize from the word go that I have not made a presentation, but I think being a subject that I deal with, I can be able to talk, and maybe people will be able to follow. I always tell medical students and other people that sometimes it is better you listen to what I say than what you see on the screen, and then you can take notes and put any questions. So I'd actually really hoped that I would be able to make my presentation after the cancer survivor had done his or her his presentation, because it will give me some bit of insights, such that my presentation becomes a bit less of theoretical, but more focused to what it is that we deal with. And I think I have 10 minutes, so I will just run through it in the format that I had in a very simplified way. So I have the honor of talking about treatment of prostate cancer. And I think last week or the 2 weeks before that, you had a presentation on an overview of prostate cancer. So I will not go back to all those. I will concentrate on prostate cancer as we know it and the modalities of treatment available. So quite broadly, we basically distinguish prostate cancer into 3 different broad categories. Initially, 2 broad categories of early or organ-confined prostate cancer, that is cancer within the prostate itself. Then we talk about locally advanced cancer, which is just going beyond the capsule of the prostate. And then we talk about the metastatic cancer, which has gone beyond and has seedlings in other parts of the body, what everybody knows as metastatic. As a preview, I will also want to just inform the audience that cancer of the prostate is one of the, we call them cancers that have been very much researched into. and very many options of treatment have been advanced. And anytime you hear medical specialists or people coming up with very many modalities of treatment, just know that it means there's no consensus, and everybody does things according to what the patient has presented with, depending on some guidelines, and depending on those guidelines where they are in Africa, in Europe, in US. There's nothing standardized. So we divide this cancer into cancer, especially let's talk about the cancer which is early, because that one is, there's very little controversy about it. Now, early prostate cancer refers to that cancer which is confined within the prostate. There are various ways that we normally grade and stage it, but it is normally maybe diagnosed either incidentally by an ultrasound that has been done, or an MRI that has been done looking for other conditions, or by some incidental diagnosis by a biopsy that was done because of a screening, as a result of some screening with elevated PSA. So it is cancer which we normally say, in over 50% of these cancers which are screened, there might not be any presentation at all, and somebody would have lived their life without knowing that they had cancer. It is important that we understand this, because it will be important in the treatment modalities which are available. Among the cancers of the prostate, may they be early or late, there might be, we normally talk about the aggressiveness of the cancer. So some cancer will be very aggressive as much as it is early. Some cancer will be very mild form, okay, what you say basically non-aggressive at all, and others are in the middle there. So we look at people and cluster them in the various categories depending on the aggressiveness of the cancer. But the two intentions are very clear with early organ confined cancer of the prostate. We want to basically achieve cure. Cure means you remove the cancer with some normal tissue of gland around it, so that the patient is completely free of cancer, and then you begin monitoring them later on. That is basically the intention of treatment of early prostate cancer. So among the alternatives available for this, the gold standard is what we call radical prostatectomy. Radical prostatectomy basically refers to complete removal of the prostate with some of the tissues that normally will be involved in the initial spread of the cancer. That will mean they're part of the seminovesicles, part of the initial part of the urethra, and part of the bladder neck, of course, sparing the urethra. Now, this can be achieved surgically by different modalities. We still talk about open prostatectomy, which can be achieved by various doctors who basically do it. And there are many approaches. I don't think this is a forum to go into it. We just need to, suffice to mention that we are able to completely remove the cancer by an open prostatectomy method, radical prostatectomy, where we remove the whole prostate and surrounding tissues that might be involved in the process. There are advantages and disadvantages of this. The common advantage is the cancer goes away in total. The length of stay in the hospital is fairly reduced, and many surgeons have successfully done this. The side effects or disadvantages of open prostatectomy, we talk about incontinence, inability to have an erection or erectile dysfunction, and normally, of course, some bit of injuries to adjacent tissues like the rectum. So these are the possible complications. After the treatment, depending on the various people who are doing it, there are people who will want to now add some adjuvant androgen deprivation, which we'll talk about later on. There are some people who will stay without. There are some people who will basically want to do what is called just waiting and seeing and acting as things develop. So there are various authorities that have studied this, and there are various medications that are there for androgen deprivation, which is denying any remnant tissues of the prostate a chance to basically begin multiplying by denying them the testosterone, which is important for their growth. Now, the other treatment which is known, that is widely used, is radiotherapy. Radiotherapy has not been very well embraced for prostate cancer in Kenya, but it's very common in other countries. The idea behind radiotherapy is you basically subject the prostate gland with the tissue that has cancer in it to radiation of measured strength, which destroys the cancer and a bit of the overlying prostatic tissue with minimal damage to the adjacent tissues outside the prostate gland. So there are two broad ways of doing it. One is by a machine which is placed external to the patient. We call that external beam radiation, or by putting implants into the prostate through image guidance. These implants end up emitting some radiation doses in measured quantities that end up killing the prostatic tissue and the cancer in it. Now, the disadvantages of radiotherapy very commonly is injury to the overlying tissues, depending on how it's done and the expertise. So you still have the possibility of having erectile dysfunction because the nerves around the prostate might be involved in the radiation. You might have some injury to the rectum, which is a very close a neighbor of the prostate gland. That's the rectum. And so people end up having some bit of bleeding or irritation. You might have some bit of incontinence if at all the sphincters are damaged. And you might even have some bit of what you call strictures or narrowing of the lumen within the prostate that people are supposed to be using to urinate. So radiotherapy in Kenya is not as popular for ourselves. I'm speaking as a surgeon. I'm sure the oncologists and other people might have a different opinion, but that is neither here nor there. So it's not very common. We prefer going with the surgical method. After the radiotherapy, we still want to subject the person to what is called follow-up androgen deprivation to eradicate or at least be able to ensure that we do not have a recurrence of the prostate cancer. Now, this is for early prostate cancer. Now, there is also, with the realization that you will be able to have, studies have been done enough to show that you can have prostate cancer that will not progress in a way to be able to cause a problem to this person during his entire life. So there is a school of thought basically that says we do nothing and either monitor the patient continuously by doing what is called watchful waiting, seeing for any evidence of worsening of the cancer or a progression, and then dealing with it there, because and some people have lived for enough years without any problems at all. The other method basically would be what you call, apart from watchful waiting, we say active surveillance, where we keep on studying the biochemical, that is the PSA, to see if at all is increasing. We do serial biopsies to see if at all there's a worsening of the grading or the stage, and then working on it. So these are modalities of treatment which are available in early prostate cancer. Now, the intermediate cancers are a bit more tricky because we're talking about a cancer that is locally advanced within the prostatic gland, occupying most of the prostate and maybe with some bit of extensions outside, but not reaching to the lymph nodes, as evidenced by either the biopsy that will have been done, TrueCut biopsy, or by what we call basically the MRI studies that are able to look at the pictures that are suggestive of cancer that has spread beyond and how far it has gone. We will also be able to know whether it is locally advanced or metastatic by doing what we call staging. Staging makes us know whether bones have been involved or not, whether the lungs are involved or not, whether other organs away from the prostate have been involved. And one of the best indicators is from the lymph nodes. So if we find it is locally advanced, the options which still are there and appropriate and are used will include: 1, the radical prostatectomy; 2, the radiotherapy. However, in these categories of people, it is definitely not in doubt that the patients have to be subjected to a further course of androgen deprivation therapy, such that we prevent further progression as much as possible and keep on doing serial monitoring of the PSA and testosterone to be able to determine whether the patient has achieved castration levels, so that we can know if at all we are at a good place or not. Now, the androgen deprivation therapies which are available are several that are used as adjuvants in locally advanced prostate cancer. It is not my intention to promote any particular drug, but I will let you know that we have the what we call the luteinizing hormone releasing hormone antagonists, okay, or other agonists, and then we also have the luteinizing hormone releasing hormone antagonists. So there are some which basically prevent the production of the luteinizing hormone from the pituitary gland, so that you have, in essence, a reduction of the stimulation of the testes to be able to reduce the testosterone levels. The other mode which has been used is paradoxically stimulating the pituitary gland in a way that is not normal, so that it initially produces a lot of testosterone, which then reduces. And I think we have a drug which I think that should be Zoladex that basically does that. The other one is Lutride. I'm using these chemical names with apologies to any sponsors who might be around, but sometimes we forget actually the generic names of these medications because of how often we use them. Now, after we subject the patient to these two options, we call this chemical castration, because the idea is to reduce the testosterone to levels that are called castration levels beyond the normal functioning of a man. There are other ways that can be used to do castration. One of them, which has been used since a long time ago, is what we call surgical castration, removing the testes, so that the only small testosterone that is there in the body is maybe the one that is coming from the conversion of estrogens and maybe from the androgen, from the adrenal glands. But these are normally very, 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 very small amounts of hormones that eventually, if at all we keep on following the patient, we are able to detect if at all there's a recurrence, and be able to deal with it accordingly. We can also be able to achieve castration by giving patients estrogen, diethylstilbistro, which has got a way of also stimulating and interfering with the production of testosterone through the hormone axis. A few other hormones, medications which have been known is the antifungal ketoconazole that also does the same, but rarely are these medications, the last two, the estrogens and ketoconazole, used on their own because of their various side effects. Now, when we detect that maybe there is a relapse for whatever reason, then we have options in these categories of patients who have already had surgery or radiation to now up and do maybe either what you call salvage radiotherapy, which is why we normally find it very useful in our purpose as surgeons to start the patient with surgery so that there is a progression. Once you start somebody on radiotherapy, then the options in terms of interventions at achieving cure are significantly reduced because there are people who have come up with the concept of salvage radiotherapy, not very popular because of the various side effects which are occasional. Now, we look at, I think I still have about 5 minutes, the metastatic cancer of the prostate, which unfortunately is the cancer that we get to diagnose most of the time in our setup in Kenya and in public hospitals where I work, and in most of the private hospitals also where I get to see patients who have come to be reviewed because of bladder outflow obstructing symptoms with suspected prostate cancer. We do a biopsy, we find it's positive for prostate cancer. It is spread out. We find that maybe a few issues, a few areas like the bones have been involved, or the PSAs are so high that you know very well for sure that it's unlikely to be early prostate cancer. Now, there are people, what I'll say is generally the approach that we take is androgen deprivation, because these are patients that we now talk about, and I'm sure somebody will come and talk about it. We are looking at palliation. Palliation is trying to basically ensure that we give somebody, a patient, a good quality of life, even as we know that the outcome is not very favorable, but you want to relieve the patient of symptoms of maybe bladder outflow obstruction, pain, which might be during micturition, or pain which might be in the back. It might be issues to do with the sexuality. It might be issues to do with other complications of malignant disease that you want to deal with. So the cornerstone of the management, we still begin with androgen deprivation, using the medications, either the medications that I had mentioned. Sometimes people combine with what we call total androgen blockade, which has some bit of, that is now you end up giving a medication that interferes with the testosterone action on tissues, and thereby you end up limiting not the amount of testosterone circulating, but rather the amount, or rather the effect of the testosterone in the tissues. This obviously has its own side effects because circulating levels of testosterone continue going up, and it basically means that you have a lot of issues with monitoring. PSA should obviously be dropping down because we are expecting to be reducing the cancer cells in circulation. So this is the gold standard, and it's supposed to basically continue throughout the patient's life. And there are patients who live quite comfortable with it. There are side effects of androgen deprivation. First and foremost is the effect of reduced circulating testosterone. Testosterone is a hormone that has several functions in a man, including basically improving the tissue muscle bulk, improving the conversion of metabolism of sugars, mineralization of bone, and generally we end up sending somebody into premature andropause, so to speak. There are medications which are available to try and mediate this, and a few patients we even put them on testosterone supplementation externally, because we know from studies that have been done, the external testosterone does not have a deleterious effect on the tissue cancer as the internally produced testosterone. And now, if what happens if at all the androgen deprivation is not successful, or now this is where now the plethora has opened with so many different options that are available. There we have what are called therapeutic agents, what we call chemicals that we will use, okay? Antineoplastic agents. Now, the antineoplastic agents are the ones which have been used for a long time is abiraterone and doxycycline, okay? This, unfortunately, are injectable medications which are given to patients and in combination with androgen deprivation therapy, not on their own as standalone treatments for prostate cancer, which is metastatic. Now, the other medications that are available, apart from these two, we have the option of giving patients some new generation we call them not really androgen deprivation, but anti-androgens. So we are able to use enzalutamide. Okay, enzalutamide is a formula that works directly on the androgen receptors pathway to be able to completely block down the production of testosterone at whichever level, so that you have what is called palliation for the patient. Now, apart from these chemotherapeutic agents which are available, or antineoplastic agents, we have the option as we keep on advancing. These are things which are experimental, but they are here with us. Remember, these are patients that are on palliation. The idea is to improve the urine flow. So sometimes we have used medications that shrink the prostate further. That is or the ones which basically allow somebody to urinate, the alpha agonist. Then in situations which, now personally as a urologist, I normally find once I reach into metastatic cancer which is not responding to androgen deprivation, I find it usually a safe thing to refer them to the oncologist. Some of them have complained that we give them the patient when they are on their deathbed, but truthfully speaking, we basically feel that the oncologists have a better place in terms of the medical interventions available in the absence of any surgery. And a lot of them have an armament of medications available to them, including hormone, not hormone, but immune modulation. We have others basically who use angiogenesis and other newer models of treatment which is available. But I will not comment much on these ones because these ones are now on the realm of the oncologists who might maybe be in the audience and they might make a comment or two. With those few remarks with this presentation, I thank you very much and hand you back to the moderator to continue the rest of this discussion. Thank you.
Thank you, Dr. Misango, for the lovely presentation that you've made today. I think we have walked the journey from the time of a diagnosis, depending on the severity of the illness. So our today was a very multi-sectoral or a very good webinar because we have a prostate cancer survivor, David Njuguna, who's with us in this webinar. And Njuguna, possibly I want you to speak to the audience of Medics and give your journey, your medical journey from diagnosis and what has been done and how you've been able to survive prostate cancer. Thank you for sharing your experiences with us today. We are very grateful. Njuguna?
Thank you, moderator. I'm ready. Thank you for having me this evening. I remember we had a almost similar talk in another time. Well, I've had the doctor talk, Dr. Misango, and I think he has mentioned quite a number of things which are very important. But now as a survivor, I think I got the things that happen in life, the ones he talk and the ones that happen, because you never really know what it is to have cancer until you have it. And I'm not praying that you do, but until you have it, at the time you know, yes, there are things that you get from doctors, from people, from friends, from many advisors, but now what you go through might be different probably, and none of the people around you has ever experienced that. Now, the most important thing with the cancer is to first of all be aware of what type of a cancer or what is the level of your cancer. That is now prostate cancer that we are talking about as men. Men generally don't like going for medical checkups. Generally, they don't want to go to hospital. And it becomes very scary when probably one has to go because of probably something has happened that is not able even to control himself, that he has to go to hospital. But eventually you end up to hospital. What I would advise the people probably who are on the webinar, those who are probably going through this, it is important to get to know about it and have yourself checked. There's usually a place that you could go and have yourself checked early enough, and so that you can be able to know what you are, so that anything that is coming up would be controlled early enough. Now, having done that, I would also want to mention that what happens when you are tested and it has become positive, that you are told that your PSA is high, the prostate gland has swollen, there are cancer cells inside there. Now, what do you do? Now, when that comes in, I believe what happened to me is that you first of all start getting worried, you fear, you do not know what to do. You look at now like you're looking at death. But I want to stand here and say, no, one doesn't have to go through that way, because I've gone through that way and I've changed my mind along the way, because I've seen what happens. Now, once the cancer is diagnosed, when it's early enough, the doctor has got the terminologies and whatever to talk about it. I thank you, doctor, because you've mentioned quite a number of words that I can't be able even to mention, but I know what physically happens. When I was diagnosed, I went through some various tests, MRI, biopsy, PSA was elevated, but not very high. But I followed it up with the doctor until it reached a state at praise that he said, now I need to get you the treatment. Then I was sent for a biopsy, which said that there was some cancer cells, though it was not very high, it was still in the early stages. I think it was in stage 2 or something like that, it could be managed. So then the next thing is, how do we manage it? I went through various things and options which were given to me, but I wish I knew what I know today. There are things I would not have done that time. But now that I'm through with it and I've been able to handle what came around, I would advise any other person, before you get yourself into taking drugs or to being treated, it's good to have the information. Information is power, we say that. And it is important that you seek all the information that you can get before you get started, before you start your treatment, so that you will be able to know what is good for you, what is not good for you, or what will this do and what will it not do, so that you are going into it with a full information of what happens. Now, in my case, what I was told after the biopsy, I was told now that it is very low. We can have the prostate removed. Well, the doctor asked a few questions, whether my age, do I have a family, and the like, of course, for obvious reasons, when you are talking about removing it. But I was with my wife, and we agreed that I need to have it removed. Just to go back a little bit, so that people don't make the same decisions. My age right now is I'm closing to 70. I'm married with 3 children who also married, and others are out of the home. So I didn't have any issues with having my prostate removed, and it was done. After that, I So the PSA went to below 0.001 or thereabout. And the doctor said, I don't need to go for radiotherapy or chemotherapy. And me, I was also not for it. So I was very happy that that happened. And to tell you that that happened in 2013. I'm coming to close 10 years again with it. So when I came out of hospital, I just took painkillers which I was given then, probably to just. But after that, I've never taken anything else. I've never taken any other drugs because nothing else has ever happened to me. I have maintained the award that the doctor said about watchful waiting. I consulted my doctor here at MP Shah because what I was doing is that I was going for PSA tests twice a month. And I would be very uncomfortable, be very scared of when I see it rising from 0. Whatever, come to 1, 2, 3, 4, and I could feel like now, where are we going to? So I talked to the doctor whom I consult, and he told me, first of all, don't be going for tests every other day. Wait for 6, 8, or 1 year, then have a test. And when I did that, I ended up having a lot of peace within myself. Nobody now, even in my family now, knew, or we even forgot that there was cancer. Despite the PSA rising, which I consulted the doctor, because the rate it is doing, it's not high. And I'm saying now, like I have lived 10 years, almost 10 years without any issues, going about my business without any worry, without any fear. I think I am going to carry on like that. That is what we call the watchful waiting. And I think for me, it is serving well. And I've been able to go about my business. So what I would like to encourage the people who have gone through this, don't get this thing into your mind that you think about it every time. It creates fear, and the fear now will bring in other things in your body, and you start wandering or running around, and it is very devastating for a person to keep on thinking that you're going out and you think, when am I going to die? And really, it's not. You're not going to die. You need to do the right things. I've made a point on myself that the food that I eat, I've got to get it sorted out. My wife, who is my best companion, takes care of me at home. The foods and the meals that we get are very, very zimeangaliwa kabisa. Those who bring in that whatever will remove the antioxidants in my body and all that. I don't take just anything. Don't take junk food. I concentrate on vegetables, fruits, water, and sometimes a bit of meat here and there, but not as I used to. There is also need to maintain, to check your weight, because I realize weight is also a hindrance, because when you become overweight, you'll not be able to go about your business. You feel tired, you feel weak, and that one will continue, because when you are not active, even other diseases fall in, and then you feel like now this is the time. But I would say it's not yet time. You still got time to go on. So my encouragement to the people with cancer is that don't give up. Get yourself, encourage yourself, move on. Don't stop doing the thing that you can easily do. Because the moment you start saying, now this one I can't do, yes, the body will like that and it will relax. Then the next thing is this one you cannot do. Yes, you take it up. I feel like I don't want to wake up. Yes, sleeping is good. And you will do next tomorrow, you'll not come out of bed. And when that happens, then you eventually become a very weak person, and other diseases might set in, and then you end up having issues. So you need to wake up yourself and do stuff which you are doing, or even forcing that, unless it is completely impossible for you to do that. But if it is possible, please go ahead and do it. you need to do some bit of exercises. I'm used to walking quite early in the morning. I walk up around 5 to 6 kilometers in the morning. That is 5 up to about 6:30 or thereabout. And I like it. Okay, right now I'm not doing it because something happened on my leg and I went for some medication. But now I would want to start up and I move on. So I encourage anybody who is going through this, just encourage yourself. You might not feel like walking, you might not feel like doing an exercise, but it's important that you do what you feel you can so that you keep yourself up. Don't burden other people. Don't say that I must be taken here, I must be taken, unless it is completely impossible. When you can, please do it, because a time will come. And I'm saying when it comes, then let whatever happens, happens. So me, I'm glad that, and I'm not talking against any treatment, but I'm glad that I didn't go for any radiotherapy, chemotherapy, hormonal therapy, which my doctor once prescribed. And again, we thought I should not go for that. And the life I'm living is like nothing ever happened. And I'm happy with that. My friends, my neighbors don't know what happened, what there is. I'm just normal and I'm moving about. So I'm expecting the next 10, 20 years, I'll probably do the same, unless something drastic happens, which I believe will not happen. And I'm moving on and encouraging myself with that kind of value. My life, my family is very supportive. And that we have put it as it's a family issue here, so that it doesn't go out, so that people don't know what's happened. Me, I believe I'm well, and I believe everybody else. You know that last time I talked about positive thinking, and I think it's very important for those people with cancer to have that positive mind. I had a friend, just to mention, I'll not mention the name, who, when we used to meet at Faraja, where we meet every second week or every second Wednesday of the month, he went through the same. The prostate was removed, but he told me, I want, when I will be buried, I want people to come and feel a heavy coffin. And we are laughing because we are friends and we are all going on well. But he said that he eats everything. Nyama iko na mafuta ni sawa kwake, sukari ni sawa kwake, junk food ni sawa, yeye hana habari. My friend, you need to watch. Well, we continue talking until one time I called, I did not answer the phone. The wife answered, and when the wife answered, I said, something must have happened. I called another time, the same thing happened. But I want to say here that if you let yourself get whatever comes in, you are taking it, you are spoiling yourself. My friend eventually passed on, unfortunately. But I think he had also encouraged his death in a way, because he said, I don't care what I eat. I want to have a good weight and whatever. Watch what you eat, exercises, make friends, fear God, and move on with the life, because life is precious and it's not good to have it terminated at that early stage. So we can still make it. My friends, every one of those who are listening, we can still make it. There is still a way out. Don't look at it as the end. That is not the end. There is still a lot of life ahead of us all, and we must make it to the end. Let not any other diseases come and play about with you. Know that you can be able to stop. You know that you can be able to move on without being discouraged by anything. So encourage yourself, stand strong. Also encourage your family. Tell them we are moving on. Everything is well. And even if there is pain here and there, eventually you take a drug or something. But let's also not discourage or rather discourage our families, our friends by telling them about whatever is happening. Stand strong and like nothing is happening. I like ladies, they're able to hold their pains through for a long time until when it is impossible. Men, let us do that. Let us be able to stand up and strong, because we are the backbone of the family, and let us be there for the family and for our every other person that relates to us. So I'm very grateful, moderator, for that opportunity. I think I've talked, well, not all, but quite a number of things. Okay, I've seen people whom we meet at Faraja, those who have gone through chemo, those who have gone through radiotherapy, and although hormonal therapy, like yesterday we were there, people are talking of the issues that they go through. The other diseases that set in, set in after these. But I sometimes myself say, I don't want to go through that. And that is why probably I held my word about watch for waiting. And I'm still going to move on with that. Unless something drastic happened, then I change, and I don't see it coming because I believe I'm moving on. So thank you very much, Rita. I really appreciate for the time that you've given. And the listeners, all right.
Thank you very much, Mr. Njuguna, for sharing your experience. Of course, doctors are also patients at a point, so I think this is also patient therapy to the participants who are logged in here, and also to listen and see the amount of work that has been done by the different teams, including the doctors, the psychologists, the family, in order to ensure that you're okay. So we had a presentation from Dr. Asaf Kinyanjui, who is the CEO of Nairobi Hospice and who's the Kenya Hospital and Palliative Care Association representative. And he will be speaking about palliative care and prostate cancer. So Dr. Asaf Kinyanjui, I hope you're on board.
Good evening, everyone. I hope you can see my screen.
Yes, you can proceed. Thank you.
Okay, thank you. I want to appreciate the organizers of this session and also my senior, Dr. Samson, for the wonderful presentation, and also Mr. Njuguna for giving us personal insight regarding the issues of prostate cancer. So this evening, I'll be discussing issues of prostate cancer in regards to palliative care. And I want to start by just highlighting what palliative care is. So palliative care, based on the WHO definition, is an approach that improves the quality of life of the patients and their families. Most of the time when we supporting cancer patients, we forget that they are coming from a family, and that family also needs to be part of the discussion. And Mr. Njuguna has highlighted the role his family has played in his journey. And it's for those patients who are associated with life-threatening illnesses, and how we do this is by issues of prevention and relief of suffering. And one of the things we need to appreciate from especially prostate cancer is that we have some patients who we know by the nature of the disease and aggressiveness of the disease, they might end up even having complications like spinal cord compression and such. So we need to look at how do we relieve and prevent those symptoms from manifesting so that at least we can be able to prevent them early enough. We also do issues of assessment and treatment of pain, which is a key component among cancer patients. We have studies have shown about 50 or so % of cancer patients experience moderate to severe pain. And unfortunately, this pain is not adequately managed. Other problems are physical issues. Some of the patients are either bedridden. You'll have other patients with psychosocial issues. And I've seen even patients also presenting with a lot of spiritual distress. So if you're going to provide palliative care to your patients, you have to be holistic in that setup, that you have to ensure that you look at a patient from that perspective, that you address their pain and other physical symptoms, you address their psychosocial issues and also their spiritual challenges. In our setup, we also realize that you need to add other components, and some of the key things which are emerging is legal issues. You'll find your patient telling you have 2 or 3 families, which I also need to ensure that are well supported, and especially if my disease gets worse. So how do you also bring aspects of legal experts so that they can also be able to support the patient? And also the final is also the financial burden that is associated with the disease. You'll appreciate the surgeries, the radiotherapies, the hormonal treatment, all these come at a cost, and most of the time you'll find patients are not able to meet this cost. So you have to also look at how else do you also support and what sort of community mobilization you're going to undertake so that to ensure that your patient gets the required financial support. And we advocate that palliative care should be provided at all levels of care, up to the community level. So from all the way from the national hospital up to the community level, these patients should be able to get the necessary support. And the new approach is that palliative care should be commenced immediately after diagnosis, regardless of the disease stage. Whether you're in stage 1 or you're in stage 4, you realize you still require some components of palliative care. And therefore, we urge our colleagues, the urologists, the surgeons, the oncologists, once you make a diagnosis of cancer, you need also to loop in the palliative care team so that they can be able to address some of the issues I've already highlighted. If we look at the essential components of palliative care, one is pain and symptoms control. Dr. Sampson has mentioned most of the symptoms associated with prostate cancer, and therefore we need also to be on board so that we can be able to address these issues. And we have seen patients even with prescriptions of for pain management, which are very not appropriate, and this subjects patients to a lot of suffering. The other component is effective communication and including breaking bad news. Again, this is an area as healthcare workers we are not doing so well. And I think the palliative care team, we tend to do a lot of damage control. So the patient will interact with the other professionals and how they talk to the patient, how they break the news that this patient has cancer and probably is in a advanced state. They do it in a very heartbreaking way. So we need to look at how do we effectively communicate with our patients so that they can understand their disease, and also they can be able to make informed decisions. And I'm happy that Mr. Jogona has shared his story and how he was able to be supported to be able to make decisions regarding his care. The other aspect of palliative care, look at rehabilitation, and especially for the patients post-aggressive treatment, continuity of care. Again, we have seen patients post-surgery or post-radiotherapy, they are lost in terms of follow-up, and the palliative care team plays a role in terms of following up these patients and up to the community level. Psychosocial care, again, this is an area which requires a lot of support. And remember, we are talking about an organ that has elements of sexuality. And when I talk about sexuality, it is slightly different from sex. If you're going to subject your patient to hormonal treatment, what are the effects of those hormonal treatments into his appearance, into his masculinity, and such issues? So we need, again, to look at how do we support our patients, how do we prepare them psychologically so that they are well equipped to deal with that, so that some of these side effects. Again, incontinence is common in prostate cancer, and it gets worse, especially if patients also are bedridden, because these patients end up even with what we call pressure sores. So we need also to look at how best do we also address the issues of incontinence to avoid psychological trauma that is associated with this. Number of our patients, we appreciate that they are spiritual, and you find patients asking you, Daktari, what have I done to my maker to deserve this illness? Why is God letting me suffer? And that also cuts so close even to the family. They start asking, why is God letting our father or our loved one be subjected to all this sort of disease and suffering? So again, we need to also look at how well, where do you support them spiritually? Social care, again, you realize most of the patients, once they are made, diagnosis of cancer is made, they tend to isolate themselves. And this also brings a lot of issues of stigma. If you realize, Mr. Jogona said, they have agreed as a family that they deal that issue as the family level. And I can appreciate, because you realize the people of the community still look at cancer as a death sentence. So we really need to look at how do we support our patients so that they are well equipped. How do we even sensitize the community so that at least they also be able to address issues of stigma. If the disease is in late stages and the patients require end-of-life care support, again, we need to look at how well do we support these patients who had end of life, so that at least even they can be able to be well supported, and the families can also be able to make the sort of the final goodbyes to these patients. And once a patient has died, how else do you support the family? And that's what we call bereavement. So that is also we can be able, the family can also be able to cope after the loss of their loved one. Issues of education are key also in palliative care, so that we need to continue doing this to educate our colleagues on what palliative care is and how best can we integrate these services in our facilities. And then finally, we also need to look at aspects of research so that at least we can have local data that can be able to guide our decisions. And now some of the areas we are looking at is what are some of the unmet needs among cancer patients from the palliative care perspective. And these are areas we should continue exploring and undertaking more research. If you look at the oncology service and regarding to palliative care, we need to appreciate that the palliative care team is core in the multidisciplinary management of these patients. They should be involved all there, as I said, from the diagnosis, evaluation, even when the patient ends up in crisis, so that at least their care is well coordinated. And there's something we talk about, even advanced care planning, so that even we can be able to tell a patient which some of the decisions do you make when you're still in stable condition. So there are some patients who will tell you, if my disease gets to levels which is already metastasis, I don't want to be subjected probably like radiotherapy, brachytherapy, chemotherapy, or I don't want to be subjected to surgery. And those things can only be done if there's proper communication with the patient and the family, so that they can be able to make advanced care planning in good time. So we really need to ensure that we also help patients to make very good goals of care. And this is also an area which we find lacking in provision of oncology care among prostate cancer patients, where the oncologist, the surgeon, the palliative care team sits down and agrees these are the goals of this patient, and this is the goals we are going to achieve as a team. And as they make those goals, they need also to ensure that the patient is at the center of that discussion and is a main decision maker, so that at least we all talk and move in one direction. So from the healthcare perspective, these are the people who should be involved in provision of palliative care: the doctors, the nurses, the physiotherapy and occupation therapists, because issues of mobilization, volunteers, and the community members. And for us, we are working closely even with the community health volunteers to help us sensitize members of the community at the community level in terms of what cancer is and how do people go for early screening and issues of treatment. The religious leaders also play a key role in terms of providing spiritual support. We need social worker who could be able to help this patient navigate through the hospital and also help the patient navigate through and especially for those patients who are not able to pay, so that he can even be able to get treatment either through waiver or through other mechanisms. The pharmacists, again, is a group we usually forget, and they play a key role in terms of ensuring there is availability of medicine and also guiding clinicians in terms of drug interaction. Mr. Jogona has mentioned about his diet, and therefore nutritionists, you also appreciate that plays a key role in supporting this patient. And from this diagram, you appreciate even that the family and friends also has to be part of this discussion. So it's therefore palliative care provision is a multidisciplinary approach, and we need to ensure that we pull all the team members so that we can be able to address all the needs of the patient holistically. There's a research which was done, and just looking at men with the metastatic prostate cancer, and it realized that they had a lot of unmet needs, and those unmet needs had a lot of impact on their quality of life and also in terms of symptoms. And therefore, it's very important to ensure that we continue having these services in place so that we can improve the quality of life of the patients and their loved ones. So if you look at some of the benefits of having palliative care services incorporated in oncology care or even in management of prostate cancer, is that improves communication between patients, caregivers, and healthcare providers. And this is an area which I feel is still lacking in our system. It addresses the needs of their caregivers as they cope with the disease of their loved one. And I've seen instances where you have a patient who is bedridden. Relatives have a lot of issues, they have a lot of needs. Sometimes even they need some aspects of respite care, where they could take a break from taking care of their loved one for a day or 2 or 3 and attend to their personal issues. And this can only be done if they have a palliative care team which is able to guide them effectively. Again, the other benefit is as it offers psychological and spiritual care. It develops also a support system to help the patient live as active as possible. And this also helps me now even looking at how do we help the patient navigate through the healthcare system and even being reviewed by other experts. The other benefit is that it improves patient and family satisfaction because patients and families are well equipped and educated, so they know what is being done and for what reason. It also reduces the costs. We have seen when patients are well empowered And then it also, when you have palliative care services, you reduce even aspects of multiple hospital admissions, you reduce even hospital stays because symptoms can be well managed and patients can continue staying at home. And that therefore reduces the cost of care. And it also enables the patient to remain as comfortable and preventing relieving pain and suffering. And especially patients with metastasis to the spine and to the bone have experienced a lot of pain. And therefore, when you have a palliative care team that is able to relieve that pain, it helps to the patient to be as comfortable as possible. It also helps in terms of maintaining connections to family and friends. And one of the things we usually do in palliative care is even organize for family conferences where you'll have a sit down between the patient and their families, and they discuss issues regarding the disease and what the next steps. And this is a very key component in palliative care. Mr. Jogona has also mentioned that they are meeting as cancer warriors. And that also helps when you have groups of patients who are encouraged to form a support group so that they're able to encourage each other and be able to support each other. So it helps in terms of even ensuring that there's that connection between even friends. Again, palliative care fosters independence because you're able to empower the patient to do things they're able to do on their own, and also helps with assisting the healthcare system, including putting together the advanced directives. As I mentioned, this is an area that is very important for us, so that at least if the patient gets to advanced stages, then you have a document that is able to guide us in terms of what should be done and what should not be done from the patient's perspective. So from this, I guess, colleagues, you can appreciate that we really need to have palliative care services in our facilities, and the palliative care team needs to be part of the multidisciplinary care team that is supporting prostate cancer patients. And finally, because I know it's quite late, I just want to leave you with these quotes. One is from the founder of palliative care movement, the Dame Cicely Saunders, and said, "You matter because you are you, and you need to ensure that even to our patients, they need to feel that they matter because they are still human beings. And as healthcare workers, that we are going to support them up to the last moment of their life, and we are going to do all we can so that we can help them die peacefully." Sometimes most of our patients don't die peacefully. They die in a lot of pain and agony. And also we need also to help our patients to live as active as possible until the time of death. We need to also to appreciate that in whatever interventions we do, we're not just putting life into we are not just adding days in their lives, but also putting life into those days. And therefore, we need also to encourage that patients need to seek palliative care services early, and you need to remove this notion that people think that palliative care is for those who are dying. Palliative care needs to be commenced from the time of diagnosis. So with that, I want to end there and hand over back to the MC. Thank you. Moderator, back to you. Thank you.
Thank you very much, Dr. Kinyanjui, for the presentation. Of course, palliative care has been one of those topics that doctors are not very comfortable with, patients are not comfortable with, families are not comfortable with. So it is important that even in the cancer control program, that these conversations and this about palliative care are held by doctors, so that we are able to be guiding to the patient in terms of what is the role of palliative care and why we need it, and in terms of going through with cancer care. So we want to thank all our presenters for today. Dr. Misango, want to thank our David, who was our survivor, and also Dr. Kinyanjui for the presentation that has been made. We have a few questions, and the KNH research team has been answering the questions as they came along, but I'll possibly go to one of the questions that has been asked, and this I will push to Dr. Misango. What is the role of bisphosphonates in prostate cancer therapy? Dr. Misango? Dr. Misango, if you're speaking, you're still on mute.
Oh, so sorry about that. Yes. The question was the role of biphosphonates in prostate cancer. Remember from the presentation, we said the metastatic cancer of the prostate has got some areas where it is not spread. Among them is the area of the hip or the pelvis and the bones. Now it causes some destructive lesion on the bones. That is in its advanced stage. And biphosphonates are important modulators in calcium metabolism, so that we basically spare the loss of calcium from bone and hence keep the bones strong. They are not routinely used in all metastatic cancers of the prostate, but rather confined to those people who are highly at risk of getting those what are called the bone complication. There's a syndrome that is associated with lots of back pain, some bit of paralysis or loss of function of limbs, some bit of problems with bladder and urine. So you get to know that this is somebody who is likely to begin having destruction of the bones, and they get what you call pathological fractures. So biphosphonates become important at that time, and they are used. Not very popular with a lot of other surgeons for reasons that, of course, we prefer irradiation of the spine for that. But basically, that is the role of biphosphonates, which may or may not be used by some people. Yes.
Okay, I've seen two very interesting questions, and I'll let you answer them back to back. One is, let me see, one is on TURP. So Norbert Pesce is asking, can you say something about the transurethral resection of the prostate? And I'll probably add to that question is it available in majority of our facilities, or where can one get it done? And at what stage is it still possible to do TURP? And another interesting question that I have seen that if the prostate is the issue, is it possible to get it removed the same way people do mastectomy if they have a higher risk of getting breast cancer before they actually get breast cancer?
Thank you. I'll take those questions. Maybe take 2 minutes to answer each. Can you say something about TURP? TURP is a minimally invasive procedure that we use. It's called transurethral resection of the prostate, a minimally invasive procedure that we use as surgeons to remove the prostate in a benign enlargement of the prostate that is causing symptoms of bladder outflow obstruction. So it is important that people distinguish between the two. Surgeries to remove a prostate that is not cancerous, and procedures to work on the prostate that has got cancer in it. Now, do we have a role of TURP in prostate cancer? Yes, sometimes, as I said, there are sometimes issues with it where there is a extensive obstruction to the blood flow, and we do what is called palliation to enable the patient to urinate by doing what is called minimal removal of the inner part of the prostate, where the patient can be able to urinate without much discomfort. Because remember, in palliation, we want to improve the quality of life. So that is about the TURP. Their opinion is divided about whether TURP for a normal, or not for a large prostate but not cancer, can result in cancer later on because of the heat which is applied. Studies are still ongoing on that, so I will not comment much. Is it true that too much of sexual act can result in prostate cancer in the long run? Can you still continue having sex at a prostate cancer diagnosis? The simple answer is the more sex somebody has, the more healthy the prostate is going to be. Okay. However, irresponsible sex that causes a lot of recurrent infection that results in repeated prostatitis can now cause recurrent irritation in the prostate and thereby predispose one to getting prostate cancer. So that question is a double-edged sword. The more ejaculations somebody has, the healthier the prostate is going to be. let's just leave it at that. Can somebody have sex after prostate cancer diagnosis? It depends on the stage of diagnosis and the state of patient's mind. The cancer itself, when it's early, somebody can go about their business without any complications or problems at all. Our live patient, Bonanjiguna, has very eloquently outlined how he's been able to go through his life. And this is not something which is completely alien, because we have a study that was done, which is called the Pivot Study, prostate cancer intervention versus observation trial, that compared over 10 years following up. Actually, we are now on the 15th years, I think, of people who had early prostate cancer, and they were followed up without any intervention at all. What is called actually watchful waiting in very simple terms. Without any intervention, no surgery, no radiotherapy, no medications, nothing at all. And their lifetime experience was nearly as good, if not better, as somebody who had intervention that early. And that has brought a lot of questions about the value of early screening, because you end up causing a lot of anxiety in patients who know now they're living with cancer and they feel something has to be done about it. But the truth of the matter is, cancer of the prostate is a very common condition that will afflict nearly every people, but the way somebody responds to the diagnosis is what influences their quality of life after that. So depending on how somebody was before the diagnosis, they might likely continue with the same way after diagnosis. If the cancer is diagnosed at a time when they have to have intervention that interferes with the sexual performance, then obviously this person will have some interference with their sexual function. Then the last question was, if the issue is brought about by prostate, why don't we just have it removed from men at some age to stay safe? Now, this is the argument that can be spun around. There are people who say, if you are known to be at risk of having breast cancer, why don't we just do mastectomy at a young age so that you do not get cancer of the gland? This is a valid question, but the answer is, the prostate gland is a sexual organ. Now, if you decide without any symptoms, without any cause, to have surgery to remove your prostate, what is the quality of your life, with knowing fully well that you are going to have all the complications of surgery or medications, okay? Let's say surgery without your prostate, and go through life while you could have waited and gotten the cancer, dealt with it, or stayed and taken your chances, live healthy and not get it. So that is something which is there. But what we know is people who got castrated, like if you get castrated at a young age, like the old, what do you call the eunuchs, you get castrated, you remove the effect of testosterone in your body, you are not going to get prostate cancer, but you're going to live a life which is miserable. It's for people to make their choices. So that's, I think those are the 3 questions which I've answered as best as I can. Back to you, Madam Moderator.
Thank you, Dr. The next, I will probably ask Dr. Kinyanjui to come in and put in a question that have been asked about medical cannabis in palliative care. What is its role?
Thank you, Pamela, for that question. Medical cannabis in the West have been shown to have positive impact. It helps in managing neuropathic pain, and also have been shown to help in terms of stimulating appetite. So it has a role, but in our setup, it's still a big discussion because of the issues of regulation. Now, how are you going to distribute this cannabis? The issues of also challenge with acceptability. You can imagine this is probably your patient is a senior church leader, and you're going to tell him to take cannabis. You might start thinking you're dirtifying the holy temple of his maker. So it has a role, but I think in our setup is still not much applicable because of the restrictions in law, and also because of other cultural influences towards issues of cannabis. Thank you.
Thank you, Dr. Kinyanjui, for that precise answer. I'm seeing people appreciating our survivor. And they're saying one is great sharing from lived experience. Thank you. And David from KEPCA is saying quite a nice session, especially bringing on board experts from care, treatment, palliation field, and more importantly, a person with lived experience. I wish Mr. Njuguna has say what Mr. Njuguna has said could be broadcasted even in mainstream media to get the message out, targeting men. Good job to all. And I'm sure Joy and her team from the National Cancer Control Program have listened to this, and I'm sure they will have more sessions with other survivors to be able to educate the men especially. The other person who has mentioned is that let me see. So someone is asking for a contact for one of the doctors, and I'm seeing Dr. Misango is actually ready to answer that. So I am really, really thankful to all over 700 participants who've been able to join in during this presentation to be able to listen about prostate cancer. And we do hope that we shall be able to have more presentations with the cancer control program on various cancers, so that for us as doctors, we are able to learn how to address our patients, and even for our patients to share with us those things that actually make sense. From this session, I have learned in terms of patient care and the importance of having family members be very key in terms of their diagnosis and also treatment. Dr. Christine Mugositati has announcements to make before we hand over to the KNH research team. I have been your moderator, Dr. Elizabeth Gitau-Maina, and thank you. Have a lovely evening.
Okay, thank you so much, our moderator, Elizabeth. You've done a great job. Thank you also to our speakers and our survivor, David. We appreciate you. My name is Christine Mugositati from the Kenyan Network of Cancer Organizations, the Executive Director, and mine is just to thank all of you for logging in today. Just to say that KENCO is a national umbrella body for cancer civil society across the country, and we, apart from working with cancer organizations, we also work with health workers. We have a component of breaking bad news where we sensitize health workers on that, breaking bad news for cancer patients. And we also distribute some cancer booklets across the country, currently working with 54 facilities in the country for patients to get to know basic information on cancer. So just to thank the Janssen team, they have been supporting us for the last 2.5 months to run a prostate cancer campaign, and we are so grateful. For the general public, we have passed a lot of information, both online through our social media platforms and with webinars. For the health workers, we have been able to reach you courtesy of KNH, and we are grateful for these webinars. So just 2 announcements. Tomorrow we'll have our final webinar for the general public, which will be at 2 p.m. You can check out the login details from our Facebook page at KENCO Network. Health workers are also welcome for this session. Then on Father's Day, that is on Sunday, we are going to have a show on KBC TV at 9 p.m. KBC TV at 9 p.m., where we'll also be addressing prostate cancer matters. In tomorrow's webinar and also for the KBC show, we'll have a prostate cancer survivor, and we are going to have a medical expert to answer some of the questions. So thank you, and you're welcome for that. Back to you. I think now I'm handing over to the KNH team. Thank you.
Okay, I've been seeing this, Dr. Gitau, I've been seeing the KNH team has been running various, on your screen, various invitation to various webinars. Of course, the KNH-UoN team have actually been very instrumental during this COVID period in terms of ensuring that our health workers are well versed with the various issues that are happening. Of course, today we've had the prostate cancer treatment. Friday 18th, we're going to have experiences managing COVID between 10 and 12 p.m., which has actually helped in terms of teaching health workers to manage COVID and giving updates. And Friday, again at 2 p.m., we'll have parents and health workers experiences of care and support after stillbirth in Kenya. So all healthcare workers are invited to these meetings. Dr. Joy, asante sana for inviting me to moderate this session. I believe we have come to an end.
Okay, thank you. On behalf of the Ministry of Health, represented here by the National Cancer Control Program, thank you to all the health workers who joined in, and thank you for the KNH team for hosting this webinar.